So valvular regurgitation or insufficiency, as we sometimes call it, results from a variety of etiology that prevent complete opposition of valve leaflets or cusp. And we sometimes divide it into what we call primary and secondary. Primary is when the valve itself is involved in the regurgitation, and then secondary when the valves are okay, everything's okay with the valve, but the apparatus that the valve that anchors the valve or surrounds the valve, we have a disease in some of those structures, which gives rise to regurgitation. So I think it's not a bad classification to talk about the valve itself causing the problem or the surrounding structure which caused the regurgitation. But it's important to identify the mechanism of the regurgitation. And the current approach is to identify the mechanism. If we're talking about primary valvular pathology, we're talking about degeneration, valvular degeneration, things like inflammation, infection, tissue disruption, iatrogenic or congenital. So those are some of the primary valvular pathology. And those of you who do scanning know that when we do, especially color flow Doppler, we can pick up, or even the pulse wave Doppler, we can pick up very small amount of regurgitation, sometimes called physiologic valvular regurgitation, even though the valve looks normal. So it's important to identify mechanism. So it's not just sufficient to say that a patient have mild, moderate, or severe regurgitation, especially moderate and severe. You can get away with it with mild regurgitation, but if we're talking about moderate and severe regurgitation, you should at least describe the mechanism, and if you can, talk about the etiology. So we're going to try and see if we can elucidate some of these mechanisms. Especially when we're looking at mitral regurgitation, there's a bunch of stuff that we can, especially in the echo lab, we can make an assessment so that the ordering physician have an idea. Is ischemic MR or is it MR due to a cardiomyopathy? So we can give that information in our report. The first test that you should do if you suspect a regurgitant lesion is your transthoracic echo. And your transthoracic echo can give you a lot of information. If the transthoracic echo, as a matter of fact, the transthoracic echo can, categorize not only the severity but the mechanism of the regurgitation. If the transthoracic is suboptimal, then you can go on to transesophageal echo or even cardiac MR, magnetic resonance imaging. Remember that cardiac MR is extremely accurate in assessment. The three-dimensional echo has helped us tremendously over the last few years to understand the mechanism of regurgitation. When we're talking about the classification of the severity, is still your two-dimensional echo. Three-dimensional echo is not a tool to talk about severity. So it's still your two-dimensional echo that you have to do a thorough investigation with your 2D echo. So when we do a comprehensive image, we need to do all the modalities that you normally do in a standard transthoracic echo. You have to do M mode because M mode will assist you in a lot of the mechanism of the mitral regurgitation, and later we'll show you, especially if we're talking about an older systolic MR, a late systolic MR, you can see that clearly on the M mode. The color M mode can show you that. So we should incorporate our M mode in evaluating these patients. And of course, your two-dimensional echo, and if you have access to three-dimensional echo, then use it. In terms of volumetric assessment, your 3D echo is very, very good. You should also do pulse wave Doppler, color flow Doppler, and continuous wave Doppler. As you'll soon find out, the color flow assessment of regurgitant lesion is probably one of the best methods to assess severity. And we will go over that, because if you can do a very accurate color flow assessment, then you get a lot of information in terms of severity of the MR. So integrative interpretation. You need to use all the modalities. Okay, it's common to see some people just look at the regurgitant color flow jet and say this is severe. No, you have to use everything. So you have to look at your if you're doing color flow, you need to look at your pizza, the regurgitant volume, regurgitant, the EROA, the effective regurgitant orifice area. You need to look at chamber size. So you need to incorporate everything. Okay. Okay. So so don't rely on just a single assessment to determine severity, because you'll be burned. And not only that, you have to individualize the your assessment, because you may have moderate MR in one patient and the patient does okay, whereas moderate MR in another patient, that patient may not be doing very well. So it depends on the etiology of the MR and the underlying cardiac condition. So bear that in mind. Not all moderate MR is the same. So you have to, when you're looking at the regurgitation, you have to look at the body size, the size of the patient, what is the cause of the regurgitation, cardiac compliance and function. Severe MR in someone with an ejection fraction of 60% is a different disease in someone with an ejection fraction of 20%. Also, the acuteness of the regurgitation. Acute regurgitation, the chambers usually are not dilated. They don't have enough time to dilate, which is different from chronic regurgitation. The chambers are usually enlarged, and sometimes you can look at the chamber enlargement to help in your assessment of severity. So, so just general approach to regurgitant lesions. So we went over this a little bit. You have to, be clear on the mechanism, the severity. If there's any other associated lesion So you have to do a complete study. Don't just get caught up with the regurgitation, whichever valve is leaking, and neglect the other stuff. You have to do a complete study. It's also important to use standard language because you will confuse people. You will confuse people. You only use echo language because, I was reading some report and I just use echo language. If you don't, you know, if you're doing echoes, you should understand the language. Don't just put down stuff because it probably doesn't have any meaning to someone who is reading the echoes. So your echocardiographic imaging now. So again, the main importance is to determine the etiology, what is causing this regurgitation, the mechanism of the regurgitation, and the severity. Okay, and then you can also look and see how the regurgitation is impacting the heart, and we call that remodeling. Because if you have a lot of blood going back into a chamber, the receiving chamber is gonna, the walls are gonna get thin and it's gonna dilate. You can also look at the valve structure, and that would help you in terms of determining the severity. And especially, when we look at the valve, the valve should co-opt in such a way as to prevent insufficiency. When we look at the mitral valve, we talk about a coaptation surface. And for the mitral valve, it's about 8 to 10 millimeters. For the tricuspid valve, it's about 4 to 9 millimeters. And for the semilunar valve, there's a few millimeters. Unfortunately, your echo, especially your transesophageal echo, is not good to look at coaptation area or coaptation. So you can do your three-dimensional T or your cardiac MR. But coaptation, because if there's a huge gap, then you can surmise that you're going to get significant regurgitation. Okay, so by just looking at the valve and looking at coaptation, you can determine, is this going to be a severe lesion, yes or no? And if you look at the valve and you have large perforations, if there is a large flail segment, if there's profound retraction, or if there's marked tenting or tethering, if there's loss of coaptation. So by just looking at how the valve closes, you can determine if this is going to be a significant regurgitation, yes or no. So, look at the valve. Look at the valve, because you might see huge gap in where the valve closes. And from that, you can deduce that the patient probably going to have severe regurgitation. So again, transthoracic echo is the main imaging modality to look at regurgitant lesions. If the 2D transthoracic echo is inadequate and don't give you all the information, then you can go on to your TE or your cardiac MR. Remember, your three-dimensional echo is going to help you with mechanism and stuff like that. Not so much in terms of assessing the severity. So you need to get your two-dimensional assessment. Um, so when you have significant regurgitation, so blood is gonna move across the valve backwards. The receiving chamber is gonna dilate, and that's what we call cardiac remodeling. So especially with chronic regurgitation, the receiving chamber is going to get larger and larger and larger. So we use that as in chronic regurgitation, the size of the chamber will help us to determine the severity of the regurgitation, because the regurgitation, the regurgitant volume, you know, it's one of the tools that we use to assess severity of regurgitation. So if we have a large regurgitant volume, then it's telling us that the severity, we have severe regurgitation. Okay. So that's it. Like in acute regurgitation, you're not gonna have chamber dilatation. You know, see, the chamber is not gonna have enough time to dilate. And there are other features of severity that you have to look at. Okay. Um, so when you use your transthoracic and you make an assessment of significant regurgitation, regardless which valve you is leaking, then you have the recommendation is to use your transthoracic echo again to follow up these patients, and you know the severity and and symptoms will determine the frequency of assessment. But transthoracic echo, that's what you're going to use to follow the patients. Um, So the echo parameters that we're going to use in a comprehensive evaluation. Um, so the patient comes in, even though you may be a technician or a physician or whatever, you're going to get some clinical information. All right. So symptoms: patient short of breath with exertion, patient short of breath at rest. You know, some basic history symptoms and other related clinical findings, and then the stuff that we normally get in the echo lab, the height and weight, so we can get a body surface area. That's crucial. So never let someone come to the lab and you don't get the height and weight, so you can get a body surface area. You may want to go back and calculate something you didn't do when the patient is in. And if you don't have those information, if you don't have those data, you can't do it. So make sure, you know, and of course, the American Society of Echo and your accreditation demands that you get these things. Blood pressure and heart rate at the time of the study should also be obtained. Okay, especially in my lab, I don't want anybody doing a study and the blood pressure and heart rate is not done. So you come now to looking at the valves, and we use our two-dimensional echo. You look at the motion of the leaflets, you know, because if the leaflets are diseased, say mitral valve prolapse or something like that, you can see that. So if the leaflets are flail, you can see that. If there's restriction, if there's tenting of the AV valves, remember tenting suggests that there is some ischemic process. So, you know, you're going to look for that. Valve coaptation, the valve closing properly, or there's a huge gap when the valve closes. Again, the structure thickening, calcification, is there vegetation, you know. Then you're going to look at your Doppler, okay? You're going to look at your Doppler. The Doppler will give you information as to the site of the regurgitation. and its direction in the receiving chamber. Remember, that's very important. We talk about the wall impinging jet, the quant effect. So look at your Doppler. Your color flow Doppler is probably one of the best tool to fully evaluate, and not only fully evaluate, but to determine the severity of your regurgitation. And the things that you're going to look in the color flow Doppler is the flow convergence, the vena contracta, and the jet area. Well, we're going to go over those things because, the vena contracta is probably the most accurate data in term to determine severity. Okay, for those people who do an exam, that's an exam question. So the vena contracta is extremely accurate. So you have to know how to measure it, and you have to know the cutoff values. Um, the density of the jet using continuous wave Doppler. So especially in your MR and your AI and your TR. So the density of the jet, the contour of the jet. Remember, we talk about triangular jets as opposed to a rounded jet, especially with patients with mitral and tricuspid regurgitation using CW. And then the deceleration rate or the pressure half time in patients with aortic regurgitation or pulmonic regurgitation. Use your CW for that. And then for patients who have mitral and tricuspid regurgitation, for the mitral, you're going to look at the pulmonary vein. And if you have flow reversal, that's a suggestion of severity. If the patients have TR, then you're going to look at the hepatic vein. If you have flow reversal there, then that suggests severity as well. If the patients have significant aortic insufficiency, then you look at the descending aorta and you get olodiastolic flow reversal. Or you can even look at the abdominal aorta, you get olodiastolic flow reversal as well. And then you can measure the LV size and the RV size as we talk about the size and pressure. Give you some information as we talk about severity. When you talk about quantitative evaluation of the regurgitation, then the pizza will go over pizza, the proximal iso, velocity, surface area. With the pizza method, we calculate the regurgitant volume and the effective regurgitant orifice area. We'll go over that when we look at the specific valve. And then we can use just Doppler technique to calculate regurgitant volume and regurgitant fraction using stroke volume. So remember, when we have a regurgitant lesion, that regurgitant lesion, and if we take an example like mitral regurgitation, then if you have mitral regurgitation, then you have backflow of blood from the LV cavity across the mitral valve into the left atrium. So the forward flow across the mitral valve in diastole is going to include the normal flow plus the regurgitant flow. So if you can calculate the flow across the mitral valve, and then if you don't have significant, say, aortic insufficiency, you calculate the flow across the LVOT, left ventricular flow tract, and you subtract that from the mitral flow, you'll get the regurgitant volume, and then you can work out the regurgitant fraction from that. So you can use just strictly Doppler to do it, or you can do it using the pizza method. And then, of course, remember three-dimensional echo. When we talk about volume assessment, for volume assessment, is three-dimensional echo. When you any volume assessment, three-dimensional echo is the way to go. and you're not going to do these studies in isolation. You want to do everything, so you're going to look at the LV and the RV size, the function, hypertrophy, the atrium. You're going to look at the size of the atrium, and then the other valves. You're going to look at them. You're going to look at PA pressures. You're going to do a complete study. All right. Your color flow is crucial in looking at these lesions. And the things that we look at is the vena contracta. So remember now, when you, so let's take mitral regurgitation, but it's the same for all regurgitant lesion. When you have backflow across the mitral valve, mitral regurgitation, the flow is going to occur just in a specific area. It's not the whole. It's not going to be chaotic and things are going to spew all over the place. That flow is going to be organized with a certain width and a certain area. When it gets into the receiving chamber now, it's going to spread out. But across the orifice that you have the regurgitation, it's going to be a certain width, and from you can calculate the effective regurgitant orifice area right at the vena contracta. So the vena contracta is that narrow area where you get the regurgitation is occurring. Okay, so we look at the vena contracta. We also look at the regurgitate, when the blood regurgitates, it occupies a certain volume in the receiving chamber. So that's a regurgitant, the jet area then. And then we look at the flow convergence. The flow convergence is going to be right at where you have the orifice, the regurgitant orifice. The flow convergence is going to be there. So what we're talking about. So if we use mitral regurgitation as an example, the mitral valve right there, LV cavity and the left atrium. When you have regurgitation, this is the regurgitant jet. This is the regurgitant jet because blood is moving from the LV cavity across the mitral valve into the left atrium, regurgitant jet. At the regurgitant orifice, it's going to flow within a narrow area, okay? And the width of this, the regurgitant jet, the orifice is called, so this is called the vena contracta, okay? This is called the vena contracta. So right at the regurgitant orifice, the width of the regurgitation we call the vena contracta, and when we talk about the EROA, effective regurgitant orifice area, is the area. So this is the vena contracta is a linear measurement. If we were to calculate the area right here, that is the EROA. Okay, so the important features of the color flow is the vena contracta, the regurgitant jet area, and then the flow convergence. So if you look at fluid, if you look at hemodynamics, any kind of fluid, if you have regurgitation, okay, you're going to have the vena contracta, and you're going to have, if it's significant regurgitation, then you have a flow convergence right there. And remember, we said that the convergence is going to take the form of a hemisphere. It's going to be hemispheric, okay? So the flow convergence is going to be hemispheric right there, and this is the regurgitant jet. And we also said that the flow, the regurgitant flow, is the same as the flow at pizza. We have the conservation of mass print, or the conservation of momentum, because we're looking at fluid. So we have to talk about fluid momentum. If you remember, the flow, so the flow across the regurgitant, or the flow across anything, is equal to the cross-sectional area times the velocity, okay? So the cross-sectional area times the velocity give you the flow. And if you want, for fluid, when we talk about momentum for fluid, it is flow times velocity. So it's flow time velocity give you the momentum. You know, if we're talking about an object, it would be the mass times the velocity. But for fluids, it's the flow time velocity. Remember, flow is cross-sectional area time velocity. So the fluid, for fluid, it will be cross-sectional area time velocity squared for the momentum of the fluid. So that is conserved. Okay. So another important principle is when we have an eccentric jet, so a wall organ jet, it appears relatively small, but if we look at the regurgitant volume, it's going to, you know, it will have the same regurgitant volume for a much, you know, a central jet that looks much larger. So you have to be careful when you're looking at wall organ jet, or we call the Cohander effect. It looks smaller, but if you were to calculate the regurgitant volume, you'll realize it's not that small. So remember the wall impinging jet. And then the Ailison velocity, or the Nyquist limit, if you reduce the Ailison velocity, sometimes these jets can look much larger than they are. So you need to note that. So don't make your velocity, Nyquist limit, too large. I mean, too small, because you're going to make the jet look too big. The orifice geometry also is an important feature, because, you know, if you have a slit-like orifice, it will tend to give you a much larger jet than, say, a rounded orifice. And the Doppler gain, it can affect what the color jet looks like. So be aware of that as well. Frequency can also affect what the jet looks like. So, you know, be aware of that. When you're doing when you're evaluating your regurgitant lesion, it's best to set your Ailison velocity between 50 and 70 centimeters per second, and so as not to over emphasize the jet. So this is what we're talking about. So the color gain, for a low color gain, you see the jet is relatively small, and then for a high color gain, the jet looks large. And this is the same patient. So by adjusting the color gain, you can make the jet look. This is the regurgitant jet. You can make the jet looks different. The Nyquist limit. This is the Ailison velocity. So if your Ailison velocity is small, remember you adjust it on the color right there. If it's small, it makes the jet large. And so, you know, 50 to 70, you get a nice jet, not too big. And then for the transducer frequency, this is not a linear relationship, but, you know, you can see the larger transducer, the larger frequency, you tend to get a somewhat larger regurgitant jet. It is not a uniform thing, however. So let us stop here. So these are general principles. When we come to the specific lesions, matter regurgitation, tracheostomy regurgitation, then we will go over some specifics as it relates to these lesions.